Yeah, thank you, madam. But thank you for this nice introduction. But the most biggest epithet of my is that I am a student of Professor Shantanu Kumar Tripathi, who is the president of this Allergy and Asthma Research Center, and I am another student of Dr. Shoibal Moitro sir, who is also a vice president of this institution. So I am very thankful to them because whatever I am now because of their teaching. So today I am going to discuss about this mainly in three broad heading. So number one, we have to understand the target because identification of target is very important to detect what therapeutics we should choose and what are the weapons that developed against the targets and what are the evidences we have. So first of all, there is one disclaimer that I am, yes, I am a clinical pharmacologist. So I will talk about mostly the therapeutics portion of the airway biologics, airway allergy and biologics. So this is a well-known picture, or we all was probably gone through it. As we all know that asthma is a heterogeneous condition in both children and adults. We have to dissect that heterogeneity, and that can contribute to our understanding of the disease pathogenesis and the development of different therapeutics strategies. Specifically, we should focus on how to manage the severe asthma or allergic disease, airway allergy. So the observable characteristics, that is the phenotype of asthma, that include the clinical features of disease and their understanding mechanisms that are a little bit complex and represent a multitude of host environment interactions. But in this particular diagram, what we want to focus that there is two type of inflammatory pathways, that is type 2 high inflammatory pathway and another is type 2 low inflammatory pathway. So type 2 high inflammatory pathway generally characterized by activation of cytokines that derive from the T helper cell 2, that is Th2 cells, and innate lymphoid cells. They includes interleukins like 4, 5 and 13. They generally induce the inflammation because of activation of eosinophils, basophils, and mast cells, which in turn lead to chronic changes in airway smooth muscle and epithelial cells that create a clinical presentation that consistent with asthma. There is a little bit difficult phenotype, that is the type 2 low inflammatory pathway. They generally characterized by activation of Th17 and Th1 lymphocyte by different types of infectious agents or some irritants. These lymphocytes stimulates the neutrophilic inflammation through different interleukins like 7, interleukin 6, 17 and 8. So if we see just this diagram, this pathway generally we came across that the B cells producing the IgE, and that attaches with the different basophils that causes release of histamines from the mast cells. Apart from that, there is another pathway, that is the interleukin 5. That interleukin 5 generally contributes from both the sides, the high T2 inflammatory states and non-high low T2 inflammatory states, and they generally recruits the eosinophils. In normal physiology, there are the natural killer T cells which causes the cytotoxic killing of the eosinophils, and generally these things hampers in presence of airway allergy. So now coming into the this diagram that shows different phenotypes. This is in normal health. We can find that airway smooth muscles are their normal epithelium and reticular basement membrane. But if we go by different types of asthma, so we can find there is eosinophilic asthma, where there is allergic eosinophilic inflammations. That means there is more eosinophil levels. that causes some epithelial damage. Mucus secretion is there, reticular basement membrane thickening is there, and airway smooth muscle mass that increased. And here we can see different cytokines, the role of interleukin 5, the Th2 mediated reactions, and the PGD2. There is lots of eosinophil recruitment and Ig mediated reactions that acts on the mast cells and that causes histamine release. Now if we go by another phenotype, that is there is high eosinophil level, but that is not typically allergic. So this is non-allergic eosinophilic inflammations. So here also we can find that there is a lots of eosinophil, but it is not due to that typical Th2 mediated reaction. So there is a role of interleukin 5 also is there, but it is not that Th2 mediated reaction. Apart from that, the low T2 react type of inflammation that generally find that polygranulocytic or non-eosinophilic asthma, there we can find less eosinophil, or that is not generally eosinophil mediated thing. There is epithelial damage is there, there is mucus production is there, but not like the eosinophilic, allergic eosinophilic or non-allergic eosinophilic asthma. Apart from that, there is another subtype, that is type 1 or type 17 neutrophilic inflammation. So there is lots of neutrophil is there, and we can find there is a no role of Th2 mediated reaction and no role of interleukin 4 or interleukin generally interleukin 5, that is not there in presence of type 1 and type 17 neutrophilic asthma. So if we now move on, that means the T2 low to T2 high. So these are the basic differences between T2 low and T2 high. So generally in our population, the most of the asthmatic patients are T2 high asthma. The studies suggest that around 50% of the asthmatic patients are suffering from T2 high asthma, but there are controversies. Some authors suggest this number is more than 50%. So generally T2 high asthma, they are commonly present as a severe type of asthma. They are more steroid responsive, they are eosinophilic in nature. There is a specific atopic component, that is Ig mediated component, and generally responsive to the T2 inhibition. Whereas the T2 low asthma is just opposite. And the difference between that T2 low and T2 high is that if we go from the T2 low to T2 high, so there will be more and more interleukin 5, interleukin 13 and interleukin 4 expression in the airways in presence of T2 high asthma. So now coming to the biomarkers in severe asthma. So this is again important to decide the therapeutics, to decide which biologic we should choose. And for that, generally the biomarkers currently used, that includes blood eosinophil count, serum Ig level, serum periostin levels or eosinophilic cationic protein charge ECP, levels of nitric oxide in exhaled breath that measured by FeNO as FeNO results, and in some centers also we can measure the sputum's eosinophil count. Sputum eosinophil counts, but not a FeNO, may help in obtaining better outcome measures, mainly in terms of reduction in exacerbations if they are used as a response to treatment with corticosteroid therapy. But of course, the sputum eosinophil count is generally not done in most of our centers. Blood eosinophil count can predict responsiveness to corticosteroid therapy. Specifically, it is very important in pediatric population. The use of biomarkers generally will be increasingly to identify patients that's suitable for specific biologic therapy. baseline blood eosinophil count is being used as a biomarker to predict the clinical efficacy of anti-IL-5 therapy, that approach in patients with severe eosinophilic asthma and with a history of exacerbation. Also, the total serum Ig level has been used as a response biomarker for the use of the anti-Ig antibody omalizumab in the treatment of severe allergic asthma. There are some studies that suggest if the FeNO level is more than 20 parts per billion and blood eosinophil count is more than 260, that generally significantly predicted those who respond with a reduction in exacerbation by the use of biologics. And this is a very cheap method, that is the calculation of blood eosinophil count, which is a good surrogate marker of sputum eosinophils. So this is one list of biologics that approved globally. So omalizumab is also available in Bharat. Mepolizumab is also approved in Bharat, but most of the other drugs is still not approved by our DCGI, but these drugs are already approved by FDA. And let's see the indications that present in that label. For omalizumab, for allergy, airway allergy, the specific indication is moderate to severe persistent asthma that is uncontrolled by inhalational corticosteroids in ages 6 years or more, but they should be positive for perennial aeroallergen. That means skin prick test is there. So dose is very much weight dependent. The frequency is 2 to 4 weekly. And there are different adverse effects. Most common is anaphylaxis, and for that one thing is very important. Generally we assume that if a patient is taking penicillin and that patient has no allergy or hypersensitivity reaction to that particular penicillin, that means if I use that penicillin in future, most probably that patient will not suffer from any hypersensitivity reaction to that particular penicillin, because the patient has a negative history to penicillin allergy. But the omalizumab, the thing is that even if after taking 1 year of omalizumab therapy, the patient may experience hypersensitivity reaction at 1 year, 2 months of therapy. So this is very important to note, and we should be very vigilant regarding the omalizumab therapy. Again, the mepolizumab, that is also approved in India, but very costly drug. The approved indication is add-on maintenance therapy for severe asthma in ages more than 12 years with eosinophilic phenotype. So 100 milligrams subcutaneously for 4 weekly. Resilizumab, that is also approved in USA, that is generally approved for add-on maintenance therapy for severe asthma in adults with eosinophilic phenotype. But the problem with this drug is this is IV infusion. So you have to admit the patient, you have to make a channel, and then you have to give. And this is again 4 weekly dose. Benralizumab, that is also add-on maintenance therapy for severe asthma in more than 12 years with an eosinophilic phenotype. Dupilumab, this is very recently approved by US FDA. That is also add-on to maintenance therapy for moderate to severe asthma more than 12 years with eosinophilic phenotype or with corticosteroid dependent asthma. All the other drugs are can be given subcutaneously except resilizumab. So now if we go back to that picture, that cartoon, then we can see the first of all the role of omalizumab, that is the anti-Ig monoclonal antibody. So they block in that part of reaction. So they block the binding of IgE to that Fc epsilon receptor present in the mast cell, and subsequent release of histamine can be blocked. Next is the anti-IL-5, that is mepolizumab. Mepolizumab generally block the IL-5 pathway, And we can see that IL-5 also contributes some type of reactions from the low T1 type of, in case of low T1 type of airway allergy also. So anti-IL-5 that blocks the IL-5 expression, and therefore there will be less eosinophil recruitment. And what does the anti-IL-5 receptor alpha, that is the benralizumab. So benralizumab also not only blocking that IL-5, they also increase the antigen dependent cytotoxicity. So they kill that eosinophil levels. So if we just see or revisit the mechanism of action of mepolizumab, that is the anti-IL-5 monoclonal antibody, then we can see that they generally produce or they generally reduce the eosinophil count through the indirect mechanism of IL-5 neutralization. Resilizumab is also an anti-IL-5, which ultimately results in passive eosinophil apoptosis and reduction. There will be passive eosinophil apoptosis that results from IL-5 ligand inhibition, likely to be slower than that achieved by benralizumab. That mechanism we will discuss, because the benralizumab mediated reaction, they generally stimulate that antibody dependent killing, antibody dependent cell mediated cytotoxicity. So this is why benralizumab action is little bit faster than the mepolizumab or resilizumab. Apart from that, benralizumab also recruits natural killer cells, and that causes the apoptosis of the active eosinophils. So benralizumab induces a rapid and near complete depletion of eosinophils via its, because it increase or enhance the antibody dependent cell mediated cytotoxicity. So now in the clinical trials, what are the results that is available with this type of biologics? So if we go by the benralizumab, they generally reduce the acute exacerbation rate by 51% at 48 weeks. Mepolizumab also reduced the same acute exacerbation rate at 52 weeks, whereas omalizumab, there is a fewer omalizumab recipients than placebo recipients experienced one or more exacerbations. That means their results is 14.6% in omalizumab arm, whereas the placebo arm has a 23.3%. So there is a reduction of 9% acute exacerbation rate. If we go by the oral corticosteroid sparing effect of these three monoclonal antibody, then benralizumab, there is a median reduction from baseline of 75% compared with placebo, that is the 25% in case of placebo arm. For mepolizumab, the median reduction of 50% that compared with placebo, and for omalizumab, there is a lesser percentage of patients taking maintenance oral corticosteroids at 24th month than 12th month, that is 16.1%, whether the baseline oral corticosteroid was 28.6%. This is not a parallel arm study. This is generally a single arm observational study. And here we can see in the benralizumab, we can find the how much it is reduced, the oral corticosteroid use. Even in mepolizumab arm, that we can find the difference. And here is the omalizumab arm. This is a single arm study, and here we can see this reduction is there, but not that much like benralizumab or mepolizumab. but we should not comment like that because there is a no head-to-head trial versus benralizumab and omalizumab or mepolizumab or omalizumab. So 52% and 18% patients completely stopped OCS on benralizumab and mepolizumab respectively. Oral corticosteroid reduction by more than 50% seen in 73% in benralizumab as compared to 54% in mepolizumab, and 70% reduction in terms of acute exacerbation rate with benralizumab as compared to 32% in mepolizumab in the same studies. So now if we just compare benralizumab, mepolizumab and omalizumab, we can find all the drugs reduce some amount, but there is much more reduction in their studies compared to their placebo, that in case of benralizumab and mepolizumab. Specifically, this is very important, that relative exacerbation rate reduction. So that percentage is around 51% in Sirocco, that is 30 milligrams subcutaneous trial, which consists 1205 patients, whether another trial that suggests 28% reduction. With mepolizumab, the reduction is 48%, 53% and 47% in different randomized clinical trial. And with omalizumab, their phase 3 trials also that suggest there is a reduction of 26%. So all these biologics has proven through different types of clinical trials. And this is one important thing, that the comparison of clinical effectiveness of this anti-IL-5 or IL-5 receptor antagonist, that is independent of co-eligibility of omalizumab. So here we can see if the patient is eligible for omalizumab therapy, then the response with either benralizumab or mepolizumab, or if it is ineligible for omalizumab therapy, then the response. But the thing is that both the eligible and ineligible group, they shows similar type of response in terms of symptom score reduction or OCS dose reduction. So here also we can see even the baseline serum Ig concentration that had no role or no effect on exacerbation frequency reduction. So this is this study is done with benralizumab. Now coming to the anti-IL-4 and that is IL-13, because these IL-4 and IL-13 are key components for Th2 pathway, and that is a key factor for pathogenesis of asthma. The interleukin-4 is important in CD4 T lymphocyte differentiation and production of IgE. Interleukin-13 that drives airway hyperresponsiveness, mucus production and subepithelial fibrosis. So we have to target these two interleukins because they also share a receptor complex like interleukin-4 receptor alpha and interleukin-13 receptor alpha. So there are several agents that was studied how to target these both interleukin-4 and interleukin-13. Lastly, we found one drug, and that is also approved by US FDA, that is the dupilumab. So dupilumab is a fully humanized monoclonal antibody to the alpha subunit of the interleukin-4 receptor, and thereby it inhibits both interleukin-4 and interleukin-13 activity. But some post hoc subgroup analysis of that dupilumab trial, there is a trend toward improvement in annualized asthma exacerbation rate was noted in two biomarkers. That is very important and very interesting, that requires further more studies. That is number one, the DPP4, that and a product of gene that is highly induced by the interleukin 13 and periostin. So DPP4 and ECP was the two important biomarkers that suggest. But we have to again another group of drug that is important, that is the lebrikizumab. And for that lebrikizumab, we found some safety concerns because this lebrikizumab is specific for interleukin 13 interleukin 13. So there are some studies that suggest that lebrikizumab increase the chance of aplastic anemia, and there are many incidents of herpes zoster infection with this particular monoclonal antibody. Apart from that, the tralokinumab, has some studies that suggest they reduce the interleukin 13 monoclonal antibody, and some clinical benefit found in phase 2 clinical trial in terms of improvement of FEV1. Next is the prostaglandin D2 receptor 2 that has also a role in Th2 pathway. Generally, this particular prostaglandin D2 receptor is responsible for the migration of the Th2 cells, and ultimately they stimulate the production of interleukin 4, 5 and 13. And generally they delays the apoptosis of the Th2 cells. So this drug, that is the fevipiprant, is a selective and potent antagonist of this prostaglandin D2 receptor 2. Another is that thymic stromal lymphopoietin. We can, if we go back to our diagram, there we can find that both the pathway, the high T2 pathway and the low T2 pathway, they start from this molecule, the thymic stromal lymphopoietin. So if we target this particular protein, then we can most probably have benefits in both type of allergic and non-allergic phenotype of asthma. So they are generally a epithelial cell derived cytokine. They drives the allergic inflammatory responses by acting through the innate immune system. They activate dendritic cells and mast cells. The level of this thymic stromal lymphopoietin protein that found the airway of asthmatics are higher when compared to the normal. And the monoclonal antibody that binds to this particular protein and prevents the interaction with its receptor is that tezepelumab. So tezepelumab can antagonize the expression of TSLP. There is a significant and persistent decrease in blood eosinophil counts, FeNO levels, and total serum IgE levels. So what are the non-type 2 targets? Why non-type 2 targets are important? Though they are less severe, but there is the entities like neutrophilic asthma is bothersome to many patients. So for that, there is one interleukin 17 receptor antagonist, that is the brodalumab. But generally the trials, the phase 2 clinical trial failed to show clinical benefit based on the asthma symptom score improvement. So brodalumab is now not that available. Again, the CXCR2, that is again a potent chemoattractant for neutrophils. So there is one antagonist to that particular receptor CXCR2. The name is navarixine. So this was in phase 2 clinical trial that shows there is a reduction in sputum and blood neutrophil count, and there is a trend toward better asthma control that based on symptom questionnaire. But the thing is that there is no significant change in FEV1. So we have some subjective benefit, but we don't find still now any objective benefits in terms of FEV1 improvement. But obviously there is a reduction in neutrophil count, specifically in the sputum and blood. There are some therapies are now investigated how to target the interleukin 6 and interleukin 33, because they also can be they also are responsible for non-type 2 or low type 2 inflammatory asthma. So for that, there are agents are now evolving. So another important area is that KIT, the specific proto-oncogene receptor tyrosine kinase. They generally found on different mast cells, and we all know that this is generally essential for mast cell development and survival. And for that, there is some study with imatinib that generally modulate the KIT level, and that improves in reduction of severity of the asthma. So how to choose a biologic medications? Generally, first of all, we have to identify the patients with severe asthma, because we have to exclude the other areas, other causes of severe asthma.
I think you're running out of time, so please.
Yeah, within 5 minutes I shall finish.
Yeah.
And apart from that, we have to determine the severe asthma endotype. So first of all, the patient's weight is very important. I am just skipping the slides. The mechanism of action we should consider before prescribing any biologic, because the mechanism of action is slightly different for benralizumab compared to mepolizumab and racilizumab, because benralizumab targets the interleukin 5 receptor as opposed to IL-5 itself. If a patient does not get benefit on mepolizumab therapy or racilizumab therapy, then the transition to benralizumab can be done. Apart from that, ease of administration is very important, and that is why the racilizumab is an intravenous monoclonal antibody, whether the mepolizumab and benralizumab are subcutaneous. And there are, we can consider the other disease also. The dupilumab is also approved for atopic dermatitis, and many of our asthma patients are also suffering from atopic dermatitis. So we can consider dupilumab when there is a coexistence of atopic dermatitis, and it has a very good role in patients who has high type 2 inflammation that characterized by higher sputum eosinophilia or higher FeNO. And we have to consider other comorbidities like chronic rhinosinusitis, and for that the anti-IL-5 drugs are very commonly used. So we can use anti-IL-5 drugs in that particular subset. And for that non-Th2 endotype, still now no approved biologic till date, but research on IL-6, IL-17 and IL-33 antagonism with some biologics are ongoing. So this is in a nutshell what are the possibility and for managing different high type 2 asthma or low type 2 asthma. This already discussed. But the thing is that one thing very important, apart from omalizumab, one drug is approved in India, that is the mepolizumab. But if we go by the prescribing information of mepolizumab, there you can find this line that is for the use only of registered pulmonologist. So if I am using this particular drug mepolizumab, so that will be a off-label therapy. So that we should all keep in mind. So that is very important regarding the prescription. The importance of going through different prescribing informations is very important, and this is the way how we achieve different types of biologics for managing airway allergy. And we should thank the researchers who are generally dealing with this evolution, so that we can get a remission. That our dream is to get the remission from asthma, as my previous speaker Dr. Rito Brodomitro has already mentioned. Thank you very much.